Hi, welcome to this section of cardiology. This is Dr. Jaitly. Here I'll be talking to you about very briefly in this video vignette, what is WPW? Time and again, once in a while, somebody comes across this term WPW. Either you went for an EKG on a routine basis, or else maybe a family member was diagnosed with WPW. He or she returns back and say, look, I was at a doctor's office and they did a cardiogram, I was told has WPW on the EKG, or somebody who was in the hospital for a WPW syndrome, etc., etc. So, plus it may be also on the boards, the exams, and one should really know it's not a fairly common condition, but still seen, reasonably from day-to-day clinical practice. One comes across on an EKG as an abnormal finding. Now, it stands for Wolfe-Parkinson-White Syndrome. Why is it a syndrome? Because it presents with some symptoms. See, if it was only an abnormality on the EKG, which I'm going to discuss, then it would not be a syndrome. So the very fact it's a syndrome, so it must present with symptoms. So because of an abnormal EKG finding, patient is prone for certain arrhythmias, and they are tachyarrhythmias, which are occurring normally from the top chambers. They occur as a result of a pre-excitation. That means normally we have an SA conduction. Look at this upper panel. So this is where if you recall how the pulse generates from the top of the roof of the right atrium, if you will. That's where the automatic pacemaker is situated. That SA node will fire, send an impulse down to AV node. This is where there is a decremental delay, and then subsequently it is transferred to bundle of His. That's a huge set of conduction fibers which divide into right bundle going up this way and the left bundle going up into the left ventricle in this fashion, ultimately branching out into Purkinje fibers. Okay, so that's the normal way of conduction. So the entire atria and ventricles are in synchrony to the level that atria will contract first, empty out into the ventricles, then the ventricles will contract and send the blood into the pulmonary artery from the right side and into the aorta from the left side, while the atria are relaxing. So essentially what it looks like is this is the normal conduction. Now, having said that, in a setting of an accessory pathway, we have the following. What happens is, look at this left panel on this side. Some of the atrial fibers have this atomicity where there's an accessory pathway. And by the way, the patients do have a normal conduction system as well, which I have not shown here, but just assuming that this normal conduction exists. In addition, there is a so-called pre-excitation. I call it short-circuiting at times. So this is short-circuiting because sending it directly into the ventricles. So look at it this way. So there is the certain set of atrial fibers. They will stimulate the atria quickly without going through this normal conduction, where there is a delay, so the PR would be prolonged up to 0.12 seconds and above. Here, they quickly generate an impulse, travels to the ventricles. Now you notice that because there is normally a delay here and it screens certain the ventricular conduction, because it has a little sieve, if you will. So this way, even if the atria were to beat fast, the ventricles will only beat to an extent. So there is a filter here, so-called. Here there is no filter. So now with an accessory pathway, whatever the rate, the atomicity of the atrial accessory pathway is chosen, it conducts into the ventricles, stimulates the ventricles retrogradely. So you see how the conduction is now going through this red arrows here? It's instead of stimulating downwards from atria to ventricles, you have an abnormal conduction going from bottom up to the top of the chambers. You see? So it is a retrograde activation via an accessory pathway called the pre-excitation, because it is occurring prematurely without any delay at the AV node. So because there is no delay at the AV node, it just prematurely, immediately sort of short circuits and stimulates the ventricles. Now, moving to the right panel, this is what it appears. It appears like a normal, see, if it was a normal conduction, it will appear like a normal P wave with a PR interval of more than 120 milliseconds, as shown here. The QRS will be less than 120 milliseconds and a normal STT pattern. Whereas in a WPW syndrome, the PR will be shortened. It will be less than 120 milliseconds. There will be a delta wave. We call it a slurring on the upstroke of the QRS. That slurring on the upstroke of the QRS, which is not present in the normal wave, is present here, and that's called a delta wave. And that occurs because of the abnormal conduction that's happening here. And now, because the ventricles are being stimulated abnormally, so the QRS is very prolonged, and it's more than 120 milliseconds. And as a subsequent, because the repolarization is also different, because now the heart will recover in an opposite way, unlike the normal way we just talked about here. So the STT changes will also appear. So in a nutshell, it's a short PR interval, less than 120 milliseconds, prolonged QRS complex, more than 120 milliseconds, a delta wave, which is a slurring on the upstroke, as I showed here in the QRS complex, STT changes as a result of abnormal repolarization, and of course arrhythmias like SVTs. So it's a complex of a lot of characteristic findings on the EKG, which will lead you to a diagnosis of WPW. Presentation sometimes, as I said, is incidental, like on a routine EKG somebody found it or was told to have, or sometimes it could be because of palpitations triggered by an SVT, rarely an AFib. At that time the rate is extremely rapid, could be dangerous and life-threatening, presenting as lightheadedness or syncope even. So in a nutshell, it's an incidental finding, sometimes presenting with symptoms, but obviously is a pre-excitation or an accessory pathway which inherently or genetically the person has, and the person gets to use it by various triggering factors, including alcohol, including stimulants, and that will facilitate this pre-excitation, or even for unclear reasons that the pre-excitation can occur in these individuals. But nevertheless, they do have a normal conduction pathway, and most of the time they conduct normally, but there will be episodes that will bring the patient to the medical attention. So it could be a serious problem during the times when the patient conducts through the pre-excitation pathway. We'll discuss the management and the treatment at a different other level, because that's beyond the scope of this video vignette. I thank you for your attention. Hope you enjoyed this section as well, and looking forward to seeing you again. Thank you. Goodbye.